All right. So good evening, everyone, and welcome to our 7th virtual shadowing session. Our topic for today, we're going to be talking about medical school clerkship during the clinical years of medical school and how to sort of navigate around that. Before we start, we're just going to briefly introduce everyone in the working group.
Next slide, Christine, please.
Sorry. There we go.
So this is kind of a working group that kind of makes all like magic happen behind the scenes. Today we have a special guest and she'll introduce herself in a couple of moments. Just a couple of reminders, we're gonna have 2 Q&A sessions, so one in the middle and one towards the end. So we'll answer all your questions at the end, so be sure to type in whatever questions you have in the text, and we'll try to get to a lot of them. And any information on the quiz, so if you have any questions on the quiz, just be patient, we'll answer those at the end as well. So information on the quiz will be provided at the end, so just be patient and stay tuned to the end. I think that's it for me, Dr. Fowler. Do you have anything else to add?
Let's have a next slide, please, Christine. We have some upcoming sessions for you. Now, for the entire group, all 948 on Zoom. And what's the count on YouTube Live right now, Shayan?
It is at 54.
Well, so to the 1,000 of you that are listening right now, we're planning to keep on doing this. As long as you keep coming back, we'll be here. Our next session is going to be the future of the study of 4-dimensional anatomy and physiology as presented by Dr. Jody Jones from UTSouthwestern's Department of Emergency Medicine. It will be most of your first exposure to ultrasound, excuse me, but also to the future of imaging. It's going to be an outstanding talk. The next one will be to work with our PA colleagues, which will be a specialty spotlight on family medicine with a physician assistant. This will be a very exciting time, including how much money do you have to borrow to go to medical school and how much money do you end up borrowing to go to PA school. You'll find that very interesting. On August 4th, Dr. Ava Pierce, a member of our Department of Emergency Medicine and a co-member with me of the admissions committee at UTSouthwestern, will speak on diversity and medicine. It will be a very exciting talk from a marvelous speaker. Our next scheduled talk is August 11th, which is on pediatrics and pediatric emergency medicine, also by a member of our admissions committee at UTSouthwestern, Dr. Pam Okeda, who's just a marvelous, energetic speaker. Tentatively scheduled for August 18th will be a trauma surgeon who is at the University of Chicago, formerly at Parkland. And on August the 25th, Dr. Angela Gardner, the past president of the American College of Emergency Physicians and a marvelous clinician who is a very, very experienced person in the finance of medicine and how physicians must manage finance and the future of the salaries of physicians. This will be an outstanding talk by a very knowledgeable person. And we're going to keep booking on out to September. If you put it in chat, if you want us to keep going, we'll keep going. We already have a dozen hours of shadowing time out that for you. We're getting all these yeses in the chat. Thank you. We'll keep doing it. We would like to put 30 and 40 hours out there, which means we've got twice as much to go as we've done so far. So you keep saying yes, we're going to be there. Next slide, please. Occasionally, I am taken with a loss of words, which people who know me say, how can that be? Tonight, I want to introduce to you one of my favorite people in the world and one of the finest clinicians I have ever had the pleasure to know. When I see her in the emergency department, I know that life is going to be okay because she's a great doctor. And I'm going to let her introduce herself. Well, I will close my remarks to introducing Christine Kulstad by this. Having been on the admissions committee now for a decade at UTSouthwestern, when it comes time for graduation, all of us professorial types get to go down and sit on the stage, put on the gown and wear that square hat that you all know about. And as the program, there's 1,000 people in that auditorium. And as the program wears on, right at the end of the program, of the graduation, this marvelous celebration, commencement really, they give the awards to the graduating class. There is an award called the Ho Din Award, which was established by the trustees of the Southwestern Medical Foundation in 1943. It is the oldest and most prestigious student award at the University of Texas Southwestern Medical School. The award is for the most outstanding medical student in the graduating class, including a certificate, a medal, and a scholarship. Would you please allow me the pleasure, and please join with me on chat with welcoming the Ho Din winner of her graduating class, Dr. Christine Kulstad. Christine, welcome.
Thank you, Dr. Fowler. Dr. Fowler likes to embarrass me by telling that story to like anyone who will listen. So I'm not blushing as much as I used to when he started doing that, but thank you for the kind introduction. What I've structured this talk to be about is like using my story of going through medical school and residency and my career so far, and using that as a way to talk about things that I could have done better, some tips for you guys as you potentially follow along in our footsteps. So I was born and raised in Chicago, but I did move to Texas as fast as I could. Those of you who live in Texas will get that. Maybe those of you who don't really understand it. But I like Chicago. It's a wonderful city, but it's very, very cold there. And by the time I was graduating from high school, I really only applied to schools in the South because I just wanted to get away from those icy, cold winters. So I went to Rice University. So my first week or so in Rice University, we had an orientation. You were supposed to pick your majors and enroll in all your classes. And I thought I would be a pre-med. And I didn't really know what that meant. I actually wrote down on my application, I'm going to be a pre-med major. And they said, well, that's not a major. You have to choose like an actual major. And I was really thrown for a loop. So they said, go talk to these students who are in the pre-med interest group. And whoever I talked to told me I had to pick a major that I could get a 4.0 in because that was the only way to be a doctor. I could only take certain classes that had easy A's, otherwise I wouldn't be able to get into medical school. And a lot of advice like that I found really unappealing. So I decided right there to not be a pre-med major and to do something else. So I wasn't exactly sure what I was going to do my first year, but I really like chemistry, and Rice is a big engineering school, so I decided to do chemical engineering. That didn't work out so well for me, but I was pursuing that, enroll in material science and engineering intro course, and I liked that pretty well, so I decided to be a material science engineer. I didn't really know what that was. I liked the class, I liked the professor, so I just sort of decided that would be a good major. I did not get any mentors. I did not get any mentors to decide not to be a doctor, which was my whole career goal for the 18 years before then. And I did not really get any good mentors to decide to be either a chemical engineer or a material science engineer. So what that ended up with is me being a fourth year in undergrad and saying, I don't know what kind of job I should get. Then I finally started talking to mentors and realizing that what you could do with an undergraduate degree in material science and engineering was not that interesting to me, at least to spend my whole life doing, and I didn't want to be an engineer. When I told my parents that, they were like, well, that's fine, but we're not paying for you to go to school anymore, so you can go ahead and graduate. It was very nice of them to pay for it at all, but it really left me in sort of like a lost place. I didn't know what to do with myself. So I ended up living in Houston for a couple of years after I graduated. I met my husband, Eric, who's pictured here. And he was someone who had done chemical engineering as an undergraduate, he did a master's in chemical engineering and had worked for a year or two maybe, and decided that this was not for him and he was going to go back to medical school. So he was talking to me about that. And I said, well, I always wanted to go to medical school. And he convinced me to take an EMT class. And that was really my first experience with shadowing or mentoring or trying out the career you're going to devote your life to. And that really made me feel comfortable that was the right career choice for me. So then I took the MCAT, the old version of the MCAT, applied to medical school. Eric was a year ahead of me in the process, so he got accepted to UTSouthwestern while I was still doing applications. So we also got married that year, so I followed him to Dallas and worked for a year in a research lab there, which was a really good experience in that it told me that my personality, the way my mind works, are not really cut out for basic science research. But I did learn a lot and meet a lot of really great people. So then I enrolled in medical school at UTSouthwestern. It was 1998. I tried to find like an old grainy picture on the internet. The plaza still looks pretty much like that. Like that view is pretty much the same, but they've added more statues and the rest of the campus is really different. At that point, medical school was 2 years preclinical and 2 years clinical. Now, when you guys are looking for medical schools, some still do it in sort of the more traditional format, but a lot of them have gone to an 18-month, 30-month curriculum. UT Southwestern did that, I think, about 4 years ago. We'll talk about some of the advantages and disadvantages of that a little bit later on. They also have developed something which they call academic colleges. Again, that's becoming more common in a lot of medical schools. So when you enter, you have an orientation weekend, I think it is. And the last thing you do there is it's kind of like a Harry Potter sorting hat ceremony. Like you go down and you get assigned to one of the academic colleges. You don't wear a hat and it doesn't read like your soul or anything like that, but you get randomly assigned to the colleges. The idea behind this was to help create a more cohesive environment, and not cohesive is the right word, cooperative environment. So you work together with this group of students all throughout medical school. It divides it into smaller groups because it can be kind of overwhelming for people who are moving to that city and don't know each other, and you're so busy you don't have time to go out and make friends the way you normally would. I think for pretty much every medical school now, the last free summer that you will ever have is between your first and second year. That comes as a shock to a lot of students because you've just been like a student for your whole life that you can remember, and you always have free summers. And then all of a sudden that's your last free summer. So try and come up with something good to do with it. It may be the best for your career goals to do a research project or some clinical shadowing. But if you don't do that, try and do something special because you don't get free summers once you finish medical school.
Christine,
Yes,
was
sir.
that the last free summer you've had since then? And since then you've been in med school and residency and practice?
Well, so we'll talk about this. We can talk about it now. I have a slide about it later. So I did Locum Tenens after I finished residency, and Locum Tenens is basically temp work for doctors. So you get assigned to different hospitals that have a gap in their staffing, or like the first place I worked was Outer Banks of North Carolina. So they have a huge increase in the people who live there in just the summer months. So they hire more doctors and nurses then. And when you do that, you have short-term assignments. So I worked for 3 months at a time and took about a month off. So it wasn't a free summer, but I did have a little bit of extended vacation then. Since then, I have not had more than 2 weeks off. So
That's what I meant, is that I suspected that ever since that time you have had your nose to the grindstone.
Yeah, it's I love this career, but it is it's hard. It's a lot of work. It's a lot of time. I remember meeting a mentor when I started medical school who told me that once you graduated, it wasn't that much better, and feeling sort of horrified by it. It is better than school. You have more money, for example. You have a little bit more time. You're more mature, but it is still a lot of work. When you do get to medical school and you're in those preclinical years, I think this is probably the case for some of you guys, at least in your larger classes, but the lectures may be streamed or recorded, so you don't actually have to go to a lot of the classes. That may work for some of you. It may not work for some of you. You want to try and figure that out pretty early on. If you are just sleeping instead of listening to your lectures and then you don't go back and listen to them, there's information that you have to learn during those lectures. So it may be better for you to get up and actually go to class. And that's just going to be individual for you. Generally, success in the preclinical years, the information that you have to learn in medical school generally is not difficult conceptually, but you have to memorize just massive amounts of information. So you have to learn all these different medications, how they act, and what they're used for. You have to learn all the diseases and the signs of the diseases, the treatments of the diseases, all the anatomy of the body. It's a lot of information to do in 18 months. I can't imagine. I mean, I had 2 years to learn all that information. I don't know how the students are doing it in 18 months now. I think it might be a little less information, but it's not much less. So it's really, it's amazing. When I work with students in academic colleges, I ask them 6 months in, did you ever think you could learn this much information in such a short period of time? And they're generally, they say no. Like they're just amazed with what they've accomplished. So to do that, you have to be very organized and very disciplined. A lot of you are very smart people, and you've been able to be successful in college with sort of like a cramming technique, where as it becomes closer to your finals, you study really hard for 2 or 3 days and you do well. Or you stay up all night and write that final paper and turn it in and you do well on it. You cannot do that in medical school. People who try and do that end up really stressed and unhappy with their grades. So you're going to have to try and find a different technique to study.
Christine, it's Ray again. As I'm getting older and losing my mind and becoming demented, I think a lot about memory and how humans remember stuff. I remember vividly back in the mid 70s when I was in med school that I felt like there was so much information coming at me that my brain was like a glass of water. And the glass of water was so full that it had a meniscus on top. And if you added another drop, something would run down the sides. I couldn't keep anything else. Did you ever feel like you, as smart as you are, did you ever feel like you couldn't keep all that stuff in your memory?
I don't know if I had the sense to think that. Like, it was just like trying to get through the next thing, like a little bit of blinders on. But yes, so there's two things that actually make that a little bit better than you might think. One is that the information builds on itself. So anatomy comes into physiology, which comes into the pathophysiology of disease, and all that stuff relates to the treatment when you're doing pharmacology. So there is some repetition. It's not all completely separate pieces of information. And the other thing that actually is pretty nice is that some of the information you're learning, like the Krebs cycle, you have to know it. And there are some fields of medicine, you have to know it during that first year of medical school. There are some fields of medicine where you have to know it your whole career. If you do genetics, you deal with inborn errors of metabolism, you're going to be really familiar with that. I never use it in my career. I haven't thought about the Krebs cycle except as like a abstract concept in a really long time. So you can forget some of that information. You just don't know when you're starting what information you can forget.
Christine, there, again, getting back to the memory thing, one device for memory is a thing called forming the memory palace. And if the students on the line, if you look that up at some point, go to YouTube, go to Wikipedia and look up memory palace. The theory is about how you link memories. And there is a company that has emerged for medical students called Sketchy Medical now that uses the technique of building the memory palace. So, for example, I recall on the Sketchy Medical discussion on Salmonella typhi, which causes typhoid fever, and Salmonella enteritidis, which causes a very severe diarrhea, that you turn the thing on and they put out there a chicken and a seagull. And you say, what in the heck has that got to do with anything? And you know what? From the memory palace perspective, I can describe that freaking seagull and that freaking chicken. And so you've worked with students, surely, that are using Sketchy Medical.
Yeah,
Could you
explain
that? Could you explain that a little bit? And what do you think about it?
They didn't have that particular product when I was in medical school. They did have something similar for microbiology where they used like cartoons and related a whole bunch of concepts in one cartoon. And Sketchy is a drawing, so there's something visual you look at. I had heard of it, but I didn't know what it actually looked like till a student showed me fairly recently. And I know at least most of the information that was represented in that panel, but I could not tell you how any of those images actually related to that information. So they do use like cute images that relate to one topic and then like put it together in a drawing. And this so he was a former student, now intern in our class, and he said he can like think back to this infectious disease and picture the sketchy image for that disease and know that there was a mouse in the corner. So that stood for streptomycin or something like that. And, so he had this whole thing that was really ingrained in his memory. So Sketchy is really good. The Anki flashcards that probably some of you have used in other courses. There are Anki decks for all the courses that you'll need. UWorld is something that a lot of the students use. I don't know that much about it. I think you have to pay for that. But there are definitely a lot of things that can help you. I think repetition is really important. What I did in medical school was we had a syllabus, so I would pre-read that. I would go to class and listen to the lecture, and then I would come home. We called it a scribing service, so one student would take notes and write really thorough notes for every lecture. So then I would read the scribed notes from the lecture from the day before. So that was like my continual cycle. So everything I read 3 times before I started studying for the test. It worked really well, but it's something that takes this sort of continual organization and discipline. You can't do that all, 2 days before the test.
You mentioned the 3 times. That's the anamnestic response to memory, which is you hear it and you remember some of it, then you hear it again, and then you remember more, and then you hear it again and form perhaps a memory palace out of it, and that gives much better recall.
Yeah. My other advice for preclinical years, it's sort of like the fun side and the not fun side. It's hard to do all this and not lose touch with your friends, your family, your significant other. So you have to schedule time with them. It also will make you like a much happier and healthier person if you schedule regular fun and relaxation. That sounds, if you're not somebody who does that already, it sounds terrible. Like, why would I schedule fun or schedule time to relax? But you really need to build that in so that you give the time that you need to your friends and family and significant others. It keeps you more balanced. And you also, like, how much time you're doing with that and how much time you're doing with your studying. If you can, I would also try and do something that furthers your career in your preclinical years. There are all kinds of like research opportunities, free clinics you can volunteer in. And then there's a lot of student groups that are more for fun, but are still things that will look really good in your CV, will have you interact with other students, faculty members, and that might be like a dance group or a singing group or something like that. So try and get involved in some of these organizations pretty early on in your career. You'll make really meaningful connections. You'll learn something different. You'll be a happier, more balanced person. And then when you go to apply for residency, you have a nice CV already there from these experiences that were pretty fun, hopefully. So after medical school, I went to residency at Advocate Christ Medical Center, which is a community academic hybrid residency program. So they've had an emergency medicine residency program for probably about 40 years now, but it's not a university program like Southwestern is. It is loosely affiliated with the University of Illinois Chicago, but they have a separate emergency medicine residency program. It's a site where they send some of their medical students. It's just outside the city limits on the southwest side of Chicago. And so it's a level 1 trauma center for the whole south side of Chicago, northwest Indiana, and like northeastern Illinois. So very, very busy, especially with all the gunshot victims that we have in Chicago. They had a lot of specialists, so they had sort of built itself up as a quaternary care hospital. But because it wasn't a purely academic center, they didn't have as many residents and fellows as, say, Southwestern. So for my training, it was really good. I worked there later as a faculty member. The downside to being in a community hospital is you have a lot of metrics. So the government ranks hospitals on all these different metrics, things like door to doctor time. So you come to the emergency room, that's time 0 when you walk in the door, and then the time ICU is my door to doc time. So we would have meetings about why our department wasn't meeting the door-to-doc goal of 30 minutes. Our ED was built for 50,000 patients, and we saw 100,000 patients. And so our door-to-doc time was 2 to 3 hours, and you really can't lower that to 30 minutes when you don't have the space to see patients. But you're still judged on that. And you're judged on a lot of different things that don't feel fair. This is one of the things to keep in mind if you're still considering a career in medicine. There's a lot of government involvement in healthcare that was supposed to be helpful and has made a lot of doctors not like their career as much. So after I finished residency, I did the Locum Tenens, like I talked about earlier. I did that for about 1.5 years. So I worked, the top picture is the Outer Banks of North Carolina. It's a series of barrier islands. It's really beautiful. It was wonderful to spend 2 different summers there. I worked in Albuquerque and in Hawaii on the Big Island. These were all really good experiences for my professional growth because it went from a large hospital with lots of specialty backup to really small hospitals where you had to transfer everyone or do things yourself. So it was a good learning experience for me. It's not for everybody, but if you have the opportunity, there are a lot of benefits, especially like having that free time. So I took months off, sort of scattered out that year and a half, and was able to travel and just enjoy life a little bit. About a year into it, I found out that my residency program where I trained was looking to hire a couple of physicians. So my husband and I decided we would go back and work at Advocate Christ. It was going to be 5 years because Chicago was still cold and I didn't really want to live there long term, but it turned into 10 years. It was a great place to work. And after a couple of, 4 years there, I ended up being the assistant residency director, which I did for 6 years. Medicine, academic medicine especially, is a pretty small community, so it's easy to stay in touch with other specialists in your field. So I'd stayed in touch with a lot of the faculty at UTSouthwestern, and when we were thinking a little bit more seriously about leaving, my husband and I decided to interview at Southwestern, and we came back at the end of December in 2016.
Dr. Kulstad, I just wanted to kind of ask you a question on, because I know you've been back and forth between Dallas and Chicago.
Yes.
Was there like sort of a difference in the culture and like how, different facilities and institutions kind of operate? And did you find that your medical training kind of prepped you for the different sorts of, dealing with different sorts of like protocols and stuff?
Yeah, there's a lot of differences. So there's differences between Texas and most other places because Texas really has its own identity that is very distinct. Chicago kind of has its own identity compared to like the rest of Illinois, but the Midwest, Illinois, Indiana, Iowa, they're all relatively similar. Doesn't have as much of a special identity as Texas does. Where I went to residency was very informal. And I think that tends to be the case in most of the Chicago programs. Southwestern is much more formal. When I talk to residents, I'll ask them to call me Christine, and they'll say, "Okay, Dr. Kulstad, I'll do that." I'm like, "No, let's go by first names." Whereas when I worked at ACMC, everyone was on a first name basis. Even with a tech who's 18 years old and just started there, they could feel comfortable calling me Christine. Some of that, though, will just vary institution to institution. It may not be as much regional. A lot of the differences that you'll see are going to be based on whether your hospital is a university-based hospital, a community hospital, or a county hospital. So right now I work just at Parkland. I don't work at Clemens, the university hospital. And Parkland is a really special place. It's a county hospital, so it's funded by the citizens of Dallas County, and it serves as a safety net for the residents of Dallas County. It has a little bit fewer resources compared to a community hospital, so maybe there are some restrictions on the medications you can use, like you can't use the newer, more expensive medications. You might have some supplies that you're not able to get. It doesn't affect medical care for the most part. A lot of these newer medicines, there's an older version that works just as well. It can be hard, though, when you're trying to get your patient, say, from the emergency medicine. A lot of times we need to get follow-up for our patients, and that is more difficult at a county hospital because it's sort of an overburdened system. I think it's really special there as a learner because when people don't have medical care, they often delay going to the doctor. So you see diseases at much more advanced stages, much more dramatic presentations than you would if someone saw a lot of medical care. And if you're an immigrant to this country, you generally don't have health insurance, or often you don't have health insurance. And so you might go to the county hospital, the safety net hospital, if you are feeling sick. And so you get to see diseases that are not common in the United States, but maybe more common in other parts of the world. So that's a really great place for like where I trained and where I work now. You get to see really interesting things. I think it's also wonderful to see patients from all different walks of life. We see people who are suffering from mental illness or substance use disorder, who are homeless, who are struggling financially. And most people in medical school, just the numbers, you might think this isn't you, but when you look at the numbers, most medical students have come from a fairly privileged background and are pretty young, so they haven't had these life experiences of seeing all the different sorts of people that you'll see at a county hospital program. We do have the university associated with Parkland, though, so we have all the students and residents and fellows and specialists to help us out in the emergency room, which is a lot of fun and a lot of good interactions. Did that answer your question?
Yeah, thank you so much.
No problem. Right. So when I came back to UT Southwestern, you did more, my non-clinical career was more focused on residency education at first, and I switched to medical student education. So I was part of the clerkship team, and clerkship is sort of the same thing as like a rotation, like a specialty rotation. So I started off advising students who are interested in emergency medicine. I taught students who were on their emergency medicine rotation. The next year I joined the academic colleges as a mentor. So I'm assigned 6 students per year, and I keep those 6 students for 4 years. We get to teach them like physical exam skills, how to interview patients. We talk about like ethical dilemmas and advising them on how to choose a career choice. Of course, they have a specialty advisor for whatever career they decide to go into, but just some sort of general ideas. And this is my favorite part of my career right now. It's such a wonderful experience to kind of see students grow and develop over the 4-year period. In 2018, the physician who was the clerkship director moved on to a different position, and I became the co-clerkship director for emergency medicine. And I interview for the admissions committee for students coming into Southwestern, but I am not on the admissions committee like Dr. Fowler. So I've been really involved with the medical students and really like that part of my career right now. Oops. All right, so just a little bit about like the clinical year. So I'm going to call it 3rd year and 4th year, or at Southwestern, it really starts like halfway through your 2nd year. So it's basically, what is that? Like 18 months, and then like the 12 months, the 4th year is pretty much the same. So in that first MS3 period, you're doing your core clerkships or your core rotations. Every school is going to be a little bit different on what they call a core clerkship. So at Southwestern, every place is going to be internal medicine and surgery and pediatrics and OB, probably psychiatry. Some places will make family medicine or neurology or emergency medicine part of their core clerkships. At Southwestern, emergency medicine is not a core rotation. These are the fundamental things that they believe every student should be exposed to help them become a well-rounded physician, and also to help them decide what they want to do. So the disadvantage to going to 18 months and 30 months is that you had to do all of your preclinical stuff in a short period of time, which is harder. The benefit is that you have more time to take electives. And electives are great for a little bit of a break, but they're also great when you're not sure exactly what you want to do. You can take a 2-week intro to anesthesiology and see if that's maybe something that you want to do, or PM&R. That's physical medicine and rehabilitation. And I still don't know exactly what PM&R doctors do. And I definitely didn't know in medical school. I didn't even consider it as a career, but I'm sure it's a wonderful job. And maybe if I'd had these electives, I would have done that. At Southwestern, like a lot of medical schools, you have to do a scholarly project before you graduate. So you have some dedicated time to do that, which is nice. And then you also have dedicated time to study for step 1 of your USMLE. And I think that's also pretty common these days in most medical schools. Now, 4th year, this will vary a little bit school to school. There's usually some sort of elective or selective. You have to usually take a couple, there's a menu you can choose from, but you have to do some real courses. What most people will do is a sub-internship or a sub-I course in whatever they think they're going to go into. So this is where our emergency medicine clerkship comes in. A lot of people do a selective in emergency medicine. If you were going to do internal medicine, you already did your core clerkship, but you still do a sub-I rotation as a 4th year. And that you have more responsibility, you're judged sort of to a higher standard. You're more like an intern your 1st year of residency, so you get a better idea of, is this something that you want to do for your whole career? You have some time where you generally don't have to do anything except interview for residency. In a normal year, when you're interviewing for residency, you're going to go to 12 to 15 different hospitals, and they're going to be probably all over the country. You've got to fly there the day before, stay in a hotel, interview, and then fly home. So it gets really exhausting and really expensive. And if you're trying to do a rotation during the same time, it just really wouldn't work out. Every school will have some special requirements that they want you to do, maybe some sort of electives. ethics course, something like that. And then most schools nowadays have a transition to residency course. It can be subdivided by specialty or something where you do all together. We have one at Southwestern. It's 6 weeks, and you spend time sort of reviewing how to do some basic things that everyone does, like ACLS training, how to write notes, how to do a handoff, like when you transfer care to another patient when you're done with your call shift, and then some things that are more specific to the specialty you're going in.
And Dr. Kulstad,
Yes.
from your own like personal experience, like did you go into, I guess, your clinical years kind of knowing you wanted to be an emergency medicine physician, or is that something you kind of like your rotations kind of helped you figure that out?
I think the rotations are very helpful. There are also some quizzes that you are assigned to take that are, maybe it's by the American Association of Medical Colleges, the AAMC, but they put together things like, what are your interests? Very generally, like, do you like having long-term relationships with patients or not? Do you like doing procedures or not? Do you handle stress well or not? And it can help you match into a career. It's kind of like those quizzes, like in a Cosmo or something like that, that tells you various things, but there's a little bit more validity to this. So you can look at that. You can, in your preclinical years, you can do some shadowing and sort of get an idea of the day in the life of a physician that way. And then when you're actually doing your core clerkships, you have a much better idea. I did not know what I wanted to do. So my husband was a year ahead of me. He was going to be emergency medicine from the first day. And my thought was, I will do something else then. That was like my main goal. I'm going to do something else. I really liked surgery. I liked the procedural aspect of it. Surgeons tend to be very decisive and very direct, and that really appealed to me. But then I did internal medicine, and I really liked that. It was like sort of more cerebral, and you got to try and work through lab results and symptoms and try and figure out what was going on, like make a diagnosis. And finally, I realized that emergency medicine sort of combined all those things, and decided to do emergency medicine. You now have to make a decision generally by the start or the first couple months of fourth year, just because of the way the application process has sort of moved earlier. It was a little later for me, so I probably didn't decide till maybe early fall, August, September of my fourth year, what I was going to do for sure.
Okay. Thank you for sharing.
Were we going to do questions now?
Yeah, Christine, let's do some questions.
Yeah.
The chat room is lit up. For example, Tej Patel asks us, Tej, says, what happens if you don't match with a residency that you think you want to go into?
So you are generally going to only apply in one field. There are some fields that are very competitive, like dermatology, for example. So you might do a backup field just in case you don't match at all in any dermatology program. But let's say internal medicine, there are a lot of internal medicine programs out there, and you can, if you talk to your advisor and follow their advice, you can set your the programs that you apply to so that you will generally be pretty much guaranteed to match in one of those programs. If you don't match, that happens. People don't listen to advice, or they just really struggle in medical school, and for whatever reason they don't match, then it's a really tricky position to be in. You'll take, generally, you have a couple options. There's a scramble, it's called, where not every residency program fills either. So you have a few days where you can try and get into one of these programs that didn't fill. If that doesn't work for you, or you decide you don't want to go through that process, you can take a year off and do like a research year, do something to try and make your application stronger so that you can go through the match again next year. If you meant, like, what if you don't like internal medicine and you go into that, you can switch fields, but it's pretty difficult. You basically have to go through the whole match again and then do a whole nother residency.
Another question we had is, do you recommend a gap year or gap years, for that matter, before you go into medical school? And do you think, in addition, firstly, do you recommend a gap year? And then secondly, if so, do you think a gap year makes you a stronger applicant if you use that time to gain some sort of experience?
Dr. Fowler has a better idea of how it looks to an admissions committee person. I think seeing students that if you take a gap year, you generally do better in medical school because you're just a little bit older and a little bit more experienced with life in general. I remember, so I had 3 years between finishing and starting medical school, finishing college, starting medical school. And I remember going back and having students who had gone straight through say things like, oh, it's so unfair that we have a test at 8 o'clock in the morning. I was like, it's not unfair. It's just when the test is, you know, if you have a job where you have to come every day at 8 o'clock in the morning, it doesn't seem unfair that someone would make you come at 8 o'clock for a test. So things like that, you just like have more life experience and it makes things a lot easier, I think.
Not uncommonly on the admissions committee for all those that are listening. And by the way, Cheyenne, if you are near a microphone, how many do we have on YouTube online?
We currently have 46.
46 plus the nines, roughly 980. So Christine, you set the record at 1,014. So good for you.
I think it's all your working group's hard work.
Working group is hard work. I know in the admissions committee, we very much look at the person, the overall person. We've gotten a question, does a community college make you a weaker candidate? No, it doesn't. We look at who all you are, who's the person, do you have community service, have you shadowed, and so forth. What do your letters say? But we try to figure out who you are. And if you're going to be a great doctor, in our case for the state of Texas, because that's what we do, the gap year should be taken by someone who wants to explore an additional area. It's certainly fine to work during your gap year. For example, Reagan Rosenberger on our working group is doing a gap year with us, and she's working for us as a research assistant in the Division of Emergency Medical Services, where she will be getting a number of papers out and so forth, and attending conference and continuing to enlarge her academic background. So, Christine, I have another one for you, and we're changing tracks. Do you have any advice for seeking mentors? That seems to be something that some of the students really struggle with, is finding someone who can help them move to the next phase. I think of a mentor like I think of that famous statue of the thinker by Rodin, where it's got his hand on his chin, his mental process, and he's thinking. I think a mentor really helps the student think. What is your opinion on that?
I was really bad at that early in my career, and I think it's really, really valuable. I think for me, it seemed that I would really be bothering someone if, say, in undergraduate, I had gone to a professor and said, "What do material science engineers do all day?" Or ask them if they had a recent graduate I could talk to about their, happiness with their career choice. It just seemed like that was putting someone else out, so I didn't do it. Most people who are in education really like students and they like mentoring students. So you should not feel, you shouldn't hesitate to reach out to someone by email. Now, you don't want to be annoying and you don't want to, show up at their house or text them night and day, but you can try sending emails to people. If you don't have the connection where you don't have anyone's email address, that makes it a little bit more difficult. You can try. So you may email the first person and they say, I can't really help you with this, but let me direct you to someone else. That's pretty common. I think reaching out and trying to get people, don't be afraid of rejection. They won't be mean to you, even if they don't want to serve you as your mentor, and you'll really generally get some good advice from the mentors that'll help you make better career choices.
Christine, we have another question that I think really, as you and I participate in the interview process for residents, and you work with the medical students and watch them to go from the second year to the third year to the fourth year, gradually maturing and getting wisdom and having vast new patient care experiences, studying and learning. The question is, it seems like there's a lot of places where students can fall through the cracks in the process of becoming a doctor. The MCAT, getting into medical school, step one, step two, matching into a residency. I mean, folks, in our emergency medicine residency of 22 residents per year, times 3 years is 66 residents. For last year, for our 22 spots, we had 1,700 applicants. If you applied to our EM residency last year, you had a 1.5% chance of getting in. It's tough. And then, of course, the board exam, and then licensing with the state. So, Christine, How did you deal with the anxiety that came from all of these different potential pitfalls?
Um, I think I have better anxiety management skills now than I did in medical school. I would say it can look really intimidating, but if you look at the statistics, you can get through this whole thing. Most people get through this whole thing. Most graduates of US medical schools are able to match in a residency. It's a little bit more difficult if you go to like a medical school in the Caribbean or internationally and you want to train in the US. But if you're a US medical graduate, if you seek out mentorship and advisors and actually follow their advice, you generally do well and you're able to match. I would say the same thing happens in medical school. If you are having trouble with your courses in the first, the preclinical years, there are, I think pretty much at every medical school, I know they have it at Southwestern, there's a group of people who are there to help you. There are people who will coach you on studying techniques. There are people like, there's counselors, whatever the problem is that's holding you back, there are people that can help you with it. And the sooner you reach out for that help, the better you're going to be. I think so many people in medicine are perfectionists and they don't want to admit that there's a problem. They don't want to ask anyone for help. And so they delay. And those are the people who end up falling through the cracks. In the academic colleges, your mentor, that's like the actual term that we use, like it's your title. But the mentor is there to help you if you're having any of these problems. They may not solve that problem, but they can direct you to someone that will help you with it. If you are on a clinical rotation and you're struggling, they can, practice presentations with you or find someone who can help you in that subject area. I think though students who don't do well don't want to admit to their mentors that they're not doing well, and so they fail to get that help. Those are the ones that fall through the cracks.
Yeah. So Christine, you've been up close and personal now with many medical students that they've gotten into school, they've spent the first year and a half studying their tails off, and now they're moving into, whereas before it was all book learning, mostly book learning, that now they're moving into taking care of patients. What kind of mental attitude transitions do you see in such a thing? Are there some students that don't do very well at that?
Yes. That's actually, I think, my next slide here. So the one thing, I was talking to Ani about this earlier, when you're doing your preclinical time, there is always some interaction with real patients. So they'll have some opportunity where you go to the hospital and you get to interview a real patient, or you go to a clinic and you watch the doctor interview patients. So you have some idea of how that happens, but you're not really good at it. So when you transition over, it's a really stressful change. So most medical schools have a day or a week or something like that where they sort of review those skills that you'll need, like how do you write a note? How do you use the electronic medical record, the EMR? How do you do suturing or scrub into a surgery? So they'll help you with that. When you start your clinical rotations, you definitely should let people know that this is your first clinical rotation. At Southwestern, in January of your second year, you could be on a rotation with someone who's in January of their third year. And so you're both medical students, and it's not immediately obvious to the resident and attending who will be evaluating you that one of you has had a year more experience. So definitely tell people that you're new, and most people, again, are in academics because they like teaching, and so they'll help you with that. Generally, in your clinical years, it's really important to be enthusiastic. If you can do a little bit of preparation before you start that rotation, so spend an hour or two before you start your OB rotation, sort of reviewing some of the common presentations or common facts that you'll need to know. That first day on the rotation, you'll really shine. There's this idea of the halo effect. So even if you don't shine with medical knowledge, if you are enthusiastic and you volunteer to be the first person to try this physical exam technique, or you'll go get the patient a blanket, or you'll do whatever needs to be done and you're enthusiastic and engaged, the people who will later evaluate you sort of take the positive feeling they have for that enthusiasm and engagement and transfer it to your other skills. It's not fair because they're sort of transferring it to something that's not exactly the same thing, but it's human nature. So if you are afraid of looking stupid and you hang back and you don't say anything, then you're going to seem disengaged and uninterested. And so you have sort of the opposite, the horn effect. They assume that you probably don't know what you're talking about. That also applies to like showing up on time and wearing either scrubs or professional gear and your white coat and having it look clean and, you know, tucked in shirt and that sort of thing. It really gives the impression of being a student who's ready to go and has their act together versus not. So that seems kind of like cheating, but it's something that's very easy to do and can help you a lot. The other thing is to don't focus on your grade. You are going to get evaluated, you are going to get a grade, and that will affect what kind of residency program you can apply to. But if you obsess about that, you will be stressed, you'll not be able to concentrate. It's also very obvious to the people you're working with that you're obsessed about your grade, and that sort of negatively influences your performance there. If you focus on the process of learning internal medicine and seeing this patient who has a really interesting disease process and learning about their disease and learning about that patient and learning how to interact with the patient, you will enjoy it much more and you'll actually do better in the end. I would say also start seeking out mentors. So if you think like I did that I might want to do surgery, then I'm going to talk with the attending that I'm working with in the surgery department. You know, it's something that you can talk about when you're between patients on rounds, but you probably also want to make a formal meeting with this person. Now, I decided not to do surgery, but I did get a letter of recommendation for my surgery attending because I had sort of sought out this relationship. And then you're going to want to get feedback because one, you want to be a really good doctor. You want to take good care of patients and you want to get feedback about how you could be better at that. And also when you get feedback, you learn how to do your job better so you'll get a better grade and a better evaluation.
Dr. Kulstad, just like
Yeah.
a follow-up to the point about mentors, how do you sort of deal with like the different sorts of personalities? Because I know every doctor, it has like a different personality and way of communicating and like teaching. So is there a way that you kind of handle that so you can kind of learn the most during your rotations and residencies years?
I think trying to be flexible. This is very stereotypical and it doesn't apply to every physician. But for example, surgeons can be like blunt. And I remember being on my surgery rotation and I wasn't scrubbed into the case. So I was in the operating room, but I wasn't like around the patient like you see, you know, in a movie. I was just sort of looking over someone's shoulder and interacting with the nurses and the team outside the operating room. And the phone rang and they told me to answer the phone. So I answered the phone and they said, "This is a message for Dr. Fowler, who was scrubbed in." So I, okay, and take the message down and went over to the table and said, "Dr. Fowler, they wanted you to know blah, blah, blah." And the surgeon was doing something very delicate and did not want to be interrupted. So I got yelled at a lot at that point. I didn't know, you know, I was doing what they told me to do. But you sort of need to realize that that interaction was more about the surgeon being stressed because he was doing a very delicate operation at that time and not about me doing something wrong. So again, sort of focusing on the bigger picture rather than your feelings will help with some of the negative interactions. And then just trying to be flexible. Like, I don't think I want to do pediatrics, but I'm going to try and see what it's like to be in the pediatric world maybe. And so that's a more gentler way of interacting with each other and with your patients than the surgery side. So I think just trying to be a little bit adaptable is the best thing there. If you don't know how the rotation is going to be, again, this seems kind of like cheating when I tell my students this, but when you show up on the first day, like, okay, how do you guys like to run your rotation? Do you want the student to come in first and see all the patients who are in the hospital beds before we round as a team, or are we doing it all as a team? Am I writing notes? Are you writing notes? Ask those detailed questions so you start off doing what they want you to do rather than finding out a weekend that you've been doing it wrong. You can also ask after a couple of days, like, is there anything I could be doing better? And ask for something specifically you should be doing. You might find out you've been giving really long presentations and they like short presentations, or vice versa. You would think they would tell you that, but that doesn't always happen. You may have had the experience of asking for feedback already and it being told something like, "Good job." That happens a lot. Honestly, if you ask for feedback, they'll say, "You're doing great," which is not helpful for your growth. It's hard to give good feedback. So what I recommend for students to do is pick an area that they feel weak in, or something they, you could just go down the line and pick a different area each day and say, you know, I would like some feedback on my presentations. Can you give me some feedback on that? And then it helps the person giving you feedback, they can focus on just that one thing rather than trying to remember when you ask that question at the end of the day, like, how did you do overall? So not that many students do these things, but they're so easy to do, and it will help you get the grade that you want and also have the process just go more smoothly because you're on the same wavelength as the person who's evaluating you and teaching you.
Right. And the whole process is kind of like it's between you, the evaluator, and then the student. Is there a way, like, how does teamwork kind of play into this, really?
So in every field might be a little bit different, but teamwork is usually something you're specifically evaluated on. So, back in the old days, I used to talk about like a gunner student so the sort of stereotypical rounding process is you have a couple of students, a couple of residents, and an attending, and you walk through the hospital and you round on all your patients. So if you're the student for Mrs. Smith, we stand outside the room and you describe what's been going on with Mrs. Smith in the last 24 hours. And then the attending or the resident asks you questions. And some of those questions will be like, what do you want to do with the patient? Or they'll ask you questions about the disease process to like probe your medical knowledge. So in the bad old days, if you were a gunner, you would answer the questions that were about the other person's patient and look smart and they would look bad. That doesn't happen that much anyway, but that also ends up hurting you because you are showing bad teamwork skills by sort of jumping in and not letting that person shine. So there's a lot of ways that teamwork shows up. In the emergency room, we see it a lot when you interact with nurses and respiratory therapists and techs and physicians from other services that come down. So we really, really, really value teamwork. Everyone value it even more. And we really look at that as a area that you should be strong in. Did that answer your question?
Yes, it did. Thank you so much. I'm sorry for interrupting if I did.
No. I love the sort of back and forth. Just if I get too off track, let me know, like you're supposed to be back here. The last thing I was going to talk about was about how COVID has affected the emergency department a little bit and medical education generally. So I think Dr. Fowler talked about this in an earlier session. When COVID first came out, we saw a huge drop in the number of patients coming to the emergency room. For some people, that was okay. But for a lot of people, they were sitting at home having heart attacks or having their appendicitis rupture and coming to the hospital much sicker later on. For us, it was weird because you would go into work and instead of seeing 25 patients in 8 hours, you would see 6 patients in 8 hours. So you kind of sat around a lot and sort of waited for this horror that you would see on the news to come to you. Gradually, after 6-8 weeks, we started seeing the regular patients come back. They realized in Dallas it wasn't that bad. It was okay to go to the hospital. They wouldn't get COVID and die. Of course, now that we're having a surge in COVID patients, we're having all those patients plus the regular patients. So it's getting pretty busy. It's not anything that you saw in the news of patients like dying in hallways and being neglected and things like that. We are managing it right now, but it's just a lot busier. For us who are working in the emergency room, this is me when I was working in the COVID pod. So this pod in particular sees all patients that have respiratory complaints or fevers. So every time you go to see a patient, you have to put all this PPE on. As the number of cases is increasing, we have to wear some of that PPE all the time. So you have to wear a face shield and a mask no matter what. You just take the gown on, gloves on and off going into different rooms. So it's annoying. It's hot or uncomfortable. It gives me a headache when I have to wear the face shield for a long time. It's really hard to talk to people. There's a lot of facial expressions you do that you lose when you're wearing all this stuff. It's sometimes hard to hear people. You can't eat or drink easily. You have to go to like a special area and be distanced in that area to eat. There's this mask-y thing that once you wear a mask for like 8 or 10 hours, your face gets sort of irritated and a lot of people are getting nasty from it. So that's all like annoyances. The clinical uncertainty of how we're supposed to treat COVID patients, or like when I work in this area, I sort of assume everyone has COVID and am I missing something else? There's a lot of things that have changed about medicine with the COVID area, especially in emergency medicine, that have been interesting. The bigger change for you guys is probably the effects on education, right? So we did virtual courses for 2 months in medical school. That's not a problem in the preclinical years, but that's a big problem in the clinical years because you're supposed to learn by interacting with patients and seeing the actual disease processes. and learning how to talk to patients and seeing physicians give bad news and things like that. And you don't have the opportunity when you're doing a virtual course and interacting like this. Students are now allowed back in the hospital, but they have limited interactions with patients, and generally they're not supposed to see patients with COVID-19. So that has made it hard to get students back with the same numbers, with the same breadth of clinical experience that they were having before. Obviously, we can't do shadowing, so we can't have you guys come in and visit with us in the hospital. Also, for the preclinical students, we talked about like using shadowing as a way to choose your career and find mentors, and they can't do that. During the process of getting into medical school and also of getting into residency, it's all going to be virtual interviews, which is really hard to shine in a Zoom format for most people. It's hard for you guys to get to know me. It's hard for me to get to know you. And then there's all the downtime in between interviews when you'd be chatting with a student. You'd be chatting with someone who's already in the institution you're thinking of joining, or seeing the physical surroundings, and you're not having that opportunity. So it's going to be a really interesting year as we figure this out. The sort of positive about this is everyone is struggling with the same issues. And we were having meetings like multiple times a week, trying to figure out how we were going to deal with this in the medical school. So I got to know so many more of my colleagues who are passionate about medical education in different fields, urologists and neurosurgeons and dermatologists and, nutritionists. And we would get on these Zoom calls and talk about how we're going to do virtual courses, or how we're going to bring people back, or how can we counsel our students on ways to find residency programs. Some of the students are on these calls as well, so they get to be involved and find mentorship and see sort of the backside of medicine. And some of the things that have come out of the virtual courses are pretty cool, and I think they'll be carried over to when we go back to regular medical education. So it's not all negative. It's all really weird. There are some negatives about it for sure, but I think trying to focus on the good things that can come out of it is the best way to get through it. All right, any more questions?
There's actually been a lot of questions from students, especially asking about your non-traditional background per se, and then what your biggest advice would be to those students as they try to get into medical school and tackle their pre-medical journey.
I guess I didn't realize how weird it was, because it was still sort of at the stage in my life where I wasn't seeking good mentorship. So I didn't talk to a lot of people. So I wasn't that worried about it when I was going and applying. Looking back, like when I actually got into medical school, I realized it was really unusual to have some gap time in between. To me, when I am interviewing a student who has a gap period, I am like really interested, like Dr. Fowler said, like what did you do with that time and how did it make you grow and develop? So I think it can really be a strength. It's just a little bit about how you sell it. So and also what you did. So if you took a year off because you were just burned out and you worked, I don't know, you worked in the mall or something, you didn't do anything interesting and you didn't gain much out of it except that you don't want to work in the mall anymore. That's not going to make you look really good. But if you do something where you're doing some research, or you are doing some clinical experiences, or even that you have a career where you are like taking on responsibility and developing leadership, those are things that are really important in medicine as well. So it can be a strength. So I definitely wouldn't think of it as a negative. If you know what you want to do, you feel really comfortable about it, and you want to go straight through, that's not bad either. I think it depends on the person and your path throughout life, which one is better for you. And it's your whole package, like Dr. Fowler said, not just whether or not you're a traditional student or not.
And kind of like as a follow-up question, I know you kind of took a break from schooling when you went through, you had a career, I guess, a brief career in between undergraduate and medical school. So how did that, how were you able to bridge that when you went to your preclinical years where it's mainly just you're in the books and you kind of have to get used to studying again? Was it kind of a shift in attitudes that you had to make, adjustment periods?
It was a little bit of a shift. For me, because I did engineering, a lot of engineering courses, like you have problem sets due all the time. So you can't ever like fall really far behind, and you spend like hours and hours working through these problem sets on a really regular basis. So that method of studying, even though it wasn't the same material and it was very different, just sort of the regularity of going through things was there. I had experienced that before. The other thing is I had, gone through this path of trying to figure out what I wanted to do with my life, which was good for me for my own growth, and did some things that I realized were not the right things for me. So when I finally started medical school, it was like, this is what I want to do. I want to work really hard on it. And I had a lot more motivation, I think, than some people might have who go straight through and are just getting tired of studying. Like I was like, bring it on. I want to learn this stuff. I don't care about, of course it gets tiring no matter what, but I was really eager to spend that time studying.
Okay. And one more question on just, I guess, the non-traditional aspect of it. But how were you able to manage like your marriage and I guess social life while you were in medical school? I know you mentioned that you got married during the first year of medical school.
Yeah, I got married right before I started. So my husband had finished his first year and I was just starting. And it was pretty unusual to be a married medical student. I think there are more non-traditional students now than there were, and there are even students who have children who come in. That seems really hard. But those students who had children, they just had to be even more disciplined and organized about things. So they had their time to play with their children and they studied after their children went to bed. It's something you just have to put a little bit of extra time into. For me, because my husband was in the same medical school, when we socialized, it was with other medical students, and he never felt like left out with my friends. When you have a spouse who does something else, it can be hard because your whole life becomes medical school, and then you go out with your friends. And even though you say you're not going to do it, you end up talking about medical school all the time. And so your spouse who's an attorney is like, I don't want to hear about this anymore. So you have to watch that a little bit and maybe develop some friends who aren't in medicine or some hobbies that aren't in medicine. A lot of this you can deal with as long as you're aware that it might be a problem or that you have to make some special effort. It's not just going to take care of itself.
All right.
So, Christine, this is Fowler. If a student already knows the field that they want to do, I mean, they've already made up their mind. They know what they want. Should they gear all of their electives toward that, or just select fun electives? Or what do you think?
So from a lot of these like advisor meetings, like we have periodic meetings that all the advisors from different specialties go to. So if you wanted to do dermatology, orthopedic surgery, urology, some of these very, very competitive specialties, they sort of expect you to have everything on your CV be geared toward that. So you are starting to join the urology interest group when you're first year, and between first and second year, you do a research project with the urologist, and then your electives sort of relate back to that. So if you take one elective that's not related to it, it's fine. But it is a very strenuous course if you want to do something very competitive. Most residency pathways are not like that. So if you want to do internal medicine, general surgery, you can have a little bit more variety. Even emergency medicine, there's a range of program competitiveness levels. So you can, you don't have to have this career that's all emergency medicine. The other thing is a lot of people who do emergency medicine like a lot of different things. So maybe they start out in surgery, they think they want to do surgery, and then it's pediatrics, and then it's something else, and they end up in emergency medicine. And that pathway is so common, doesn't hurt you at all.
Christine, you've been in private practice and you've been in academic medicine. What made you seem to, I mean, I work very closely with you and I know you pretty well. You seem to be very happy and that you found your spot with you and your husband, Eric, in an academic practice. Do you envision yourself going back out to the privates, or do you think you found the spot where you want to stay? And if so, why?
I'm very happy in academics. To me, even though emergency medicine is super varied, after a while, the things you see the common stuff pretty commonly. And after doing it for 10 years, the sort of thrill of doing emergency medicine, just that it's different and hectic and crazy, wears off. And so you have to have some area of interest in your field that's keeping you engaged. And for me, it's in education and teaching. So mentoring residents and teaching medical students, one, it makes me stay at the cutting edge of medicine because that's what they're learning. And so they're asking me questions about it, and I've got to stay up with that. So that keeps me engaged with my field. And the sort of extra part of teaching keeps me really engaged. For other people, it may be forming like relationships with their patients on a deeper level. It might be getting involved in the hospital setting, like doing administration in the hospital setting. So those are ways you can make community medicine really appealing to you. But for me, the education part of academic medicine was the thing that gives me a lot of joy.
One interesting question is, what if you end up deciding the field you want to go into later? And then maybe you don't have the specific extracurricular courses to what you end up being interested in. Can that cause a problem?
It can for some of the competitive fields. So I was on a panel discussion with, I think they were first year students who are asking, everyone's sort of the career path. And there was a dermatologist on the panel, and she didn't decide till later. So this is one of the super competitive specialties that you're supposed to have everything on your CV look like dermatology. And she ended up taking a gap year and doing research within medical school. So she spent, took a, I don't know if it was between second and third year or third and fourth year, but took a year off, did research in that department so she could then make her application into what it should be. And she also got to form really deep relationships with that department, and that is where she matched. So there are ways around it. It just may be non-traditional. It may, we'd all like to just finish and get done with medical school, and she had to extend her training a little bit.
Dr. Kulstad, there's been a lot of questions from students on step 1 and step 2, and I guess recently the change step 1 to pass fail. Yeah, how do you think this is going to affect residency applications, and specifically like how is it going to affect students as they transition to like from the preclinical years into clerkship?
I think it will make the process of studying for step 1 a lot better. I didn't realize how much my students were stressing. So they get, I think it's 6 weeks to study for step 1, and all they're doing is spending like 12 hours a day trying to study. You can't really focus for 12 hours a day. So they're just sort of torturing themselves trying to study, every single day for, days and days on end. And then they're taking practice tests and they're not doing as high as they want to do. And they're stressing even more and they can't really concentrate. And it sounds really miserable. So I think the fact that it's going to go pass fail is going to help with that. You learn the material that you need to know, and then it's just pass fail. The downside is no one knows how it's going to affect residency application. So I think, unfortunately, some of that pressure of having to do well in step 1 is now just going to get transferred to step 2. Most students take step 2 before they apply to residencies. So orthopedics, where you had to get, a high score on step 1 to be considered competitive, I think you're just going to have to get a high score in step 2. Your grades will probably be a little bit more important in some of the more competitive specialties. What the positive that people say is it'll make us look at your applications in more detail and try and understand you as a student overall and not just look at like a number. But we haven't really gone through that process yet to know if that will actually happen. It will probably make being a well-rounded student a little bit more important.
Christine, as I understand it, step 2 is not pass-fail. It has its own
Correct.
score.
Yes. Yeah, only step 1 will be pass-fail. At least this first iteration.
Christine, how has being a woman, do you think, affected your EM experience, or has it at all? Rashi Kedia, who spoke about 3 weeks ago, said that she was sort of, what's the word I want to use? It's sort of almost a personal bias that she made herself dress the part as a doctor. She wore the white coat with the stethoscope in it and so forth. What have you found from a gender perspective? Is it been more positive for you or negative? People call you nurse or?
Yes, 100%. So until COVID came, I wore a white coat to every single shift that I worked in the emergency department. And that was, I mean, it's nice to have the pockets, and I get cold easily. So there's, some other reasons, but it was mostly so that I would have this external, I am the doctor thing. And I would walk in and say, I'm Dr. Kulstad. And especially in some older patients, they'd say, oh, honey, look, the nurse is here. I'm like, I just said I was a doctor. I'm wearing a white coat. Like, why would you assume I'm the nurse just because I'm female? So that stuff is there. I think it's getting better, but it's still there. Some of the interactions you have with colleagues can be, like, it can be harder to be an authority. So to tell a nurse you have to go do this without seeming bitchy, basically. So that's an issue that women have in a lot of fields. If you're going to be in a powerful position or a leadership position, sort of figuring out how to do that without being judged harshly. I don't have the solution to that problem, but it does exist in medicine, as well as, if you want to be the CEO of a company, you're going to have to deal with that issue. I don't think, things like, this Me Too movement that you heard a lot about in Hollywood, that people being sexually harassed. I haven't seen that happen in medicine. I think it used to be a problem way back in the day, but I don't think that's an issue too many people have to deal with anymore.
Risa, is there a serious phase that you click into when you get a very sick patient? I was watching you recently, and I went over to the critical pod where you were working, and there was a patient who had dislocated his shoulder, and I was about to have to be put, basically very sedated or even put to sleep, to put the shoulder back in. And I was coming over just to chat and say hello, and you were bolt upright, turning around, looking at the room and say, we are now about to do the timeout for this patient. And it was so clear, the commanding pose that you had taken. I turned around and walked out of the room.
I remember that.
I did not want to butt in, because I could see that you were in this very serious mode where you would have to take a patient to basically unconsciousness, which means near death potentially. And I just saw that in you. Do you feel that when you click into that mode, Christy? Or is that just so natural that it just comes natural?
No, I think it is something that I have to, there's a mental sort of shift that you do. That this is really serious, and you have to pay a lot of attention when you're doing something that's risky. I would hope that everyone still has something that they're changing about the way they interact, because you can't be that intense all the time. It'll drive you crazy. But when you have the really sick patient or the really risky procedure, whatever it is, you need to be focused. And hopefully I don't scream at the medical student when they come in. But this is sort of thing like that surgeon was doing. You're doing something where you have to focus 100%. So you don't want a lot of interactions. A lot of distractions, interruptions. That's what I was trying to combine. That one thing I had meant to talk about earlier, but didn't, was some of the challenges of being a clinical medical student. Ani and I had a conversation before this talk about some of these issues. So in medical school, everyone that enters medical school for the most part is a really good person. They want to do medicine because they want to make the world a better place and they want to help people. And then your preclinical years, you're learning all the science, but you're also learning some of the social aspects of medicine and how disparities in our social system affect people's health. And so you become even more empathetic. They studied this, they measured empathy. You became more empathetic. And then you go to your clinical years and you become less empathetic. And it's to me, it's a fascinating concept. Why does this happen? We take these bleeding heart people and then we make them, sort of tough and less empathetic. It's not that big of a decline, but there's a decrease in empathy. And one of the reasons that they theorize for this is, one of the reasons is the bad role modeling. So Dr. Fowler and I are, mean to you, and then you become a little bit jaded. Hopefully that doesn't happen too much. But the other thing is, it's really jarring to be a physician early on. And so you go and see patients on your internal medicine rotation, and you meet a young woman who's dying of breast cancer and has 2 kids, and she's 35 years old, and it's just horrible. And not many people have had close friends or family go through these really terrible experiences, and to see sort of over and over again people going through things that are really difficult is very trying on you mentally. You'll have rotations where people die. One of my students started his clinical rotations with trauma surgery, and on his first day of his clinical rotation, one of the first few patients that he saw came in, lost all his vital signs, basically died, and they did all these very invasive procedures, cutting open his chest and putting in lines and transfusing blood. The room gets trashed because everyone's just trying to do everything they can to save this person. They're doing CPR, and then the person died, and it was a young person. So this was, it would be a very difficult experience for any student to go through, but it was his first clinical experience. Thankfully, the attending there did a debrief with all the students so they could sort of talk about their emotional reaction to it, but that doesn't always happen. And so students don't always have good coping mechanisms to deal with these really difficult situations. It's also hard just to see people naked. We don't do that in our day-to-day life. So when you walk into a room and you're expected to I'm a doctor, this doesn't bother me at all, but you're sort of just trying on that persona. All these things are hard, and you're doing them all very, very quickly, and it's hard to adapt to them. So I wanted to say, before you start your clinical years, trying to have some way that you'll deal with these different stresses sort of pre-identified is going to be really helpful to you, and maybe help with that empathy decline, prevent you from getting burned out. So a family, support system, friends, church group, meditation, whatever it is, something that can help you deal with these negative experiences that you'll unavoidably have.
Christine, you were married to an emergency physician, Eric, and how does working both of you shifts in the same ER, is that easy or hard? I mean, you get to request your schedules, but I bet you don't always get the schedule you want, because most of us don't. So how does coming and going like two ships passing in the night work for you, for the two of you?
I think it works pretty well. We don't have kids, but I know a lot of other physicians that I work with who have a spouse who's also in emergency medicine. So it's nice in some ways to not work the same shifts, because whatever responsibilities you have outside of medicine, there's one person at home to deal with the kids or let the dogs out or whatever that is. It's nice to work together because you can drive in together and drive home together. But when you're at work, you're generally too busy, so you're not really interacting with each other. So that's not that big of a deal. Luckily, most people like Eric. So when I go to work, they say nice things about him, and they say nice things about me to him. So we're not hurting each other in that way. And then we sort of know the same people, which is good and bad, because it's hard to leave work at work sometimes when you come home and you can keep talking about this crazy case you had. So I think it has its advantages and disadvantages, but it's worked out pretty well for us.
So Christine, are you burned out? Do you think you're burned out? Our good friend, our dear friend that you knew, Compton Broders, defines burnout as the response of a normal person to a toxic environment. Do you think you're burned out?
I don't think I am now. I think when I came to Southwestern, when I left my old job, I was feeling a little bit burned out, and I didn't really realize it till I I lost some of those symptoms. So I talked about the metrics at my old job, and I felt that they were overwhelming the pleasure that I had interacting with patients and interacting with residents. To know that, oh wait, I didn't put in the chart that the reason I didn't do this in this particular time frame, or I didn't choose this antibiotic that I know they're going to send me an email about, why didn't you use that particular antibiotic? You're just it feels like someone's watching you all the time and judging you in a way that's not, are you a good doctor, but are you doing this sort of arbitrary checklist of things? Where I worked, Press Ganey patient satisfaction survey was very, very important. Right about the time I left, they started posting in the physician lounge, where every physician in the hospital would go to get coffee. They would post every physician's Press Ganey scores. And it's a very imperfect measure of what it's trying to measure, which is patient satisfaction. And patient satisfaction is a very imperfect measure of, are you a good doctor? So to have something, your bonuses or your salary could be tied to that, and you'd have to justify why your score dropped down 2 percentage points. Those sorts of things may be a little bit burned up.
So let me change tracks for a minute. And Christine, thank you so much. This is a wonderful session. You should be seeing the chat light up. Everybody say thank you, Dr. Kulstad, in the chat for me. Let's see 1,000. They're popping into the chat. Thank you with with all caps and 15 exclamation points. Christine, for introverts, what specialty do you feel best would fit that?
So I'm an introvert, and I am probably in the wrong field in terms of that sort of thing. Emergency medicine is stereotypically an extrovert's field, so don't 100% go by that. But if you wanted to just use that characteristic, something like pathology or radiology or anesthesiology would probably be more of an introvert's field. I would say you can make everyone gets sort of like a work personality or your game face. You can make that match whatever you want to do. So don't limit yourself just based on if you think you're an introvert or an extrovert. But if it's really something that bothers you a lot, you can do radiology or pathology. In particular, you don't interact with too many new people.
That's certainly a possibility. The thing that's critically important and that everyone on the call has to understand, that regardless of your personality characteristics, what you're doing is something that has to be ruthlessly honest. You have to know what you're talking about. You have to become a specialist in your field, which means owning a body of applied scientific knowledge that makes you as virtually reliable in your impressions of your work, of the things that you say. If you say it, it is so, because your training and your experience mean that your opinion is an informed opinion by someone who's dedicated to their field. Personality characteristics notwithstanding, you may be a radiologist simply reading chest x-rays in a darkened room and interacting very little with other folks, but your opinion, your medical opinion, your scientific opinion has to be ruthlessly informed on an ongoing, steady, personal improvement basis. So I just wanted to chime that in. Christine, we've been going for an hour and a half, and you have just been absolutely remarkable. Ani, what other questions do we have?
We have a couple of questions, I guess. In the Q&A, there was a question that asked how admissions views military service, or how you...
Positively. I think it's very positive for medical school, and it's definitely very positive for residency. You have done a difficult job generally. If you've been in the military for a while, you've learned discipline, and you also tend not to complain very much, which of course your supervisors like a lot, especially in residency. We're like, ooh, yeah, they'll just do what we tell them to and not complain. I'm joking a little bit, but the military people do have that advantage of, we sort of assume you're going to be a hard worker and not complainer, and you're going to be disciplined and reliable. The other category that is beneficial in both groups, and I know probably more about the residency application side of it, is if you're a college athlete, because it's difficult to be a college student and an athlete at that level. Like, it takes a lot of time management skills, a lot of discipline. There's usually a lot of teamwork involved in most college athletics as well. So we sort of assume that you're going to have all those qualities.
Yeah. And there's a question that asks, so I know you mentioned there's a lot of memorization that's going to happen during the preclinical years, but how does sort of understanding the material sort of come in? Like, is there, are you still able to emphasize understanding even though you are memorizing a lot of information at the same time?
So there is a period in the preclinical years where you start learning more about diseases, and that's usually when the understanding comes in. Like, you just have to learn some basic facts before you can really get to the the fun stuff. And once we get to that stage, we do a lot of like case-based learning in the colleges system. So we'll get together. We have actually 2 groups come together. So there's 12 students and 2 mentors, and we run through a case. And so the students have to, and it's pretty preliminary at the stage, but they'll come up with like the different kind of diagnoses that they think could be going on, and what is, what supports that, or what decreases that likelihood, what kind of tests they would order. And then when we come to the conclusion of the case, what sort of treatments would be necessary for this patient. And so to me, that's one of the most fun things in medicine, is trying to figure out what's going on. And so you start doing that process probably at about maybe 6 to 9 months in. And that's when the understanding of how all these things interact starts becoming more and more important, and not just memorization of facts.
Ani, anything else?
There was a question on how, I guess, medical schools have improved teaching how to deal with patients of different backgrounds, especially you mentioned that medical students often come from a different background than the patients themselves.
Yeah.
So patients that are, minority or underprivileged. Has there been like improvements in like sort of training when it comes to that?
Generally, yes. It's going to vary school to school. Like some schools are going to be just amazing, outstanding at it, and some are going to be, the majority are going to be average, and there are a few that are probably not doing it much at all. So like we talk about these issues in the preclinical years in the colleges sessions, because I see it so much at the county hospital system. Like I feel like I probably stress it maybe more, not more than I should, but I stress it a lot. Like, how does this patient interact with the healthcare system, and how might your plan for them differ based on different sort of backgrounds? There are like formal sessions that students have on diversity and inclusion. I know that it's an elective course, but we have a course in the preclinical years and another one in the clinical years about social determinants of health. So how does all those factors, like your socioeconomic status and your racial status, how does that influence your health care? So it is becoming more talked about in medicine. I think with all the protests that happened after George Floyd's death, like it became even more of a thing than it was before. So there's a lot of different groups that I'm involved with in academic emergency medicine, and they were all talking about what else do we need to do to make this, to make emergency medicine in particular, but to make medicine a better agent for change in our society.
And I know you ended on COVID. So just a question on how the students are currently doing their clerkship rotations over at Parkland, or just any medical school right now. What do you think that they should be learning from this crisis? And how do you think that they should take this so that, once they become future physicians and residents,
I think it's affected their education, probably at this point mostly a negative way. So hopefully they can be part of the agents for change, for making our education system more robust to deal with the next pandemic, if there is one. I think there are probably physicians who are 5 or 10 years out, and even 20 years out, who didn't really think of how they would react to dealing with patients who potentially have a disease that could kill them. And so all of you guys and all the people who are currently medical students have probably thought through that. Like, how would I feel about taking care of a patient, especially doing something invasive that's going to get droplets all over me? Would I be comfortable doing that? So when COVID came through, there were physicians who didn't want to see patients who were potentially COVID for various reasons. So, and like when AIDS first was diagnosed, there were physicians who didn't want to take care of patients who had AIDS because they were afraid that they would get it. So I think, every couple of generations, there's something that goes through that helps you decide where you're going to be on that spectrum, and if you're comfortable with it. There are people who I know who thought about leaving medicine because they were so worried about their health, especially before we knew, like when we thought COVID was maybe more deadly than it's turned out to be.
Okay, and Dr. Fowler, just so I know how much time we have. How many more questions do you want to take?
Well, we've been going an hour and 40 minutes. Let's take
That's
five
probably
more. Let's do, Christine, can you handle 5 more minutes?
sure.
Okay, great. If you have a question, put it in the chat, folks.
There was a question I think that mentioned, are there any cons to doing, I guess, the Locum Tenens after residency?
I don't think there's a big, I didn't find it to be the case. I kind of worked fair. I knew I wanted to probably do academics. So when I was in residency, I was doing things, again, that would be on my CV that would support that. So I did some research projects and teaching things. So taking that year off and not doing anything like that didn't really hurt me. If you hadn't done that and then did locum tenens and then said, oh, now I want to do academics, you might be like, well, I don't see that in your track record. If you wanted to just go into the community, it shouldn't be a problem.
Christine, do medical schools have specific training on dealing with grief? And also, well, it's really an and/or how to work with patients who are dying specifically?
There is some training. They actually do role playing. One of the things that our students do in the 4th year, I think it's in that transitions course, but they have to do role playing, like giving bad news and talking to patients about goals of care. So if someone has advanced cancer, for example, like how do you ask them what's important to them about the time that they have left and how to have that conversation. So we talk about it in colleges periodically throughout the years, and then there's a much more focused emphasis on it before you graduate medical school. Hopefully you're also getting that experience in some of your rotations, getting to watch those conversations before you have to be the one actually having them.
There was a question that asked how your EMT background kind of helped you.
He left down the way. Hello?
It helped a little bit. So you do, like I said, you're doing sort of case discussions in your preclinical years, and there's words like tachycardia, which a lot of the people in my small group didn't know what it was, because you have to learn kind of a whole new language when you start medical school. And being an EMT, you know, I was like, oh, that means rapid heart rate, and I could help people. I also had a little bit more comfort in like touching other people. It sounds really weird, but it's something as a society, you don't just like go up and, you know, put your hand on someone's chest to listen to their heart. So that sort of interaction, I'd broken through that a little bit, but there were pretty minor things. If you haven't done EMT, it wouldn't hurt you. It did just make some of those early experiences a little bit more comfortable.
There was another question on, I guess, step 1. Does the pass-fail kind of hurt DO students that are trying to match into MD residencies? I don't know. So there is it's not universal, but there is a pervasive idea that MD residencies sometimes look down on DO students. I've heard it explained that there's more variability in the training a DO student gets than an MD student, so that people feel like they don't know if the student's as well qualified. I don't know if that's just an excuse, but there definitely is a bit of a prejudice there. So if you're taking your step scores and we can see that you have really high step scores, or, you know, whatever criteria that residency is looking for, then they might feel more comfortable that you got the training that they're looking for. So I could see it potentially hurting. We don't know for sure though.
Sorry, my computer is talking. Excuse me. Beg pardon. Christine, this has been, I didn't mean to interrupt you if I did.
No. I was going to say maybe that's a good second place.
Well, that's a good segue now that the computer started talking to me. Everybody, we've been going now for an hour and 45 minutes. We are so grateful to Dr. Christine Kulstad, a wonderful physician who is recognized by all of us here at Southwestern as being one of the kindest and most sincere and supportive individuals that we all know. Christine, this has been just a marvelous sharing of your thoughts about how you got here, and and what are you doing, and your observations about medical students, and who are those that make strong candidates for residency, and who are those that are struggle, and possibly how those that are struggling can move beyond their struggling to be able to find their pathway. On behalf of the whole working group of the virtual shadowing, you are now officially family. And we just thank you so much. The praises are pouring in on the chat right now, and I hope you can see that. To all the group, to all the over 800 that are still online with us, we really appreciate this. We're going to keep doing this if you keep coming back. Does someone have Ani?
Oh yes, sorry. Dr. Kulstad did it. No,
I realized there was one more.
Yeah, there was a slide on the assessment that we just wanted to make sure it was out so all the students can see it. But just go on to QuestBase, and the pin and the password is Chicago, and they're all lowercase. So as usual, you guys have to
Damn, the video just finished too. I gotta go home now too. Was in Zoom call?
Reagan, mute everyone, please, and then Christine.
I think
and
Zoom is about to die, and then COVID-19 makes Zoom like popular. They come back. They even do like a big
Reagan, would you mute everybody, please?
You can touch it up. They was dying until COVID-19 saved so much company. Like mask
I'm not
wearing
sure how to do it actually.
The person who owns it has to do it. Yeah.
Oh,
whatever.
Well, thank you, whoever that was. That was very interesting. So everyone's shaking their heads and laughing on the chat. All right, folks, check the pin out, 7453-6270-4779. Password is Chicago. The exam will be posted until midnight on Friday night. So anyway, as long as you keep coming back, folks, we're going to be here for you at virtualshadowing.com. Dr. Kulstad, again, from a very grateful working group and audience, we thank you for your time. And to everyone, we wish you a good evening and good night.
Thank you all. Take care.
Thank you.